Welcome to Bird Ultrasound. The material that you're about to view is an archive edition of my hip ultrasound lecture. If you like this material, please visit birdultrasound.com.au to view a large selection of freshly recorded ultrasound education material on a wide variety of topics. Happy scanning.
The hip's an interesting joint for ultrasound. Intuitively, I've always thought of the hip as being a bad joint for ultrasound. It's a very deep joint, often in a larger patient, so you need to use slightly lower frequency transducers. It's a deep ball and socket synovial joint, so I think of it probably more like the knee than I do, say, the elbow or the wrist. So intuitively, I always think that it's not a great joint for ultrasound, but over the years I've grown to love the hip and really feel that ultrasound has a great role to play in the hip. Anatomically, a deep ball and socket synovial joint, as I said, it has similar characteristics to the shoulder in as much as that it has a labrum here, the joint space, and then a sort of a recess here, a reflection of the synovial joint space here, so that you can see coming down the neck of the femur if there's a joint effusion. What you do see on ultrasound is the joint capsule, and the joint capsule is this thick iliofemoral ligament. Now, the iliofemoral ligament is the echogenic structure that you see that stays concave with the femoral neck that tells you there's no joint effusion. When the joint effusion occurs, it displaces this iliofemoral ligament anteriorly towards you and bows it into a convex shape, and that tells you that there's a joint effusion. If you look at the relative size of the labrum compared to the iliofemoral ligament, you'll see it's a very small structure, and that's what it looks like sonographically. The labrum is very tiny, and I have no faith whatsoever in ultrasound diagnosing or sort of excluding labral tears. I will show you how we can diagnose labral tears, but you can never say for sure the patient does not have one, because I've scanned many patients that have got proven labral tears with MR that you simply can't see on ultrasound, even in hindsight and knowing that it's there. So it's a bit like the shoulder in that respect as well. Let's have a look. So this is what it looks like on ultrasound. You can see this concavity of the femoral neck, and there's the femoral head covered in beautiful hyaline cartilage, which is the black stuff. Sitting anterior to it, you can see this thick white layer, and it extends all the way down here to this point here, which is the intertrochanteric line, and that is the point of the attachment of the iliofemoral ligament to the femoral neck, and that demarcates the distal extension of the joint space. So providing that the femoral neck is concave, which it will always be, then if the iliofemoral ligament is concave as well, therefore you should have no joint effusion, and that's what we're seeing here, a nice dry joint. This is a healthy joint. The labrum sits just in here, a very, very small structure, just underneath the iliofemoral ligament, just in this structure here. And if you look, as I scan through at the level of the femoral head here, you'll notice one other piece of anatomy, and that is that you'll see something that looks remarkably like the long head of biceps tendon. Just there, it's coming into view. And this is the iliopsoas tendon. Of course, the iliopsoas muscle is the muscle that's all superficial to that, and it's building its tendon posteriorly in close contact with the anterior rim of the acetabulum, and then the hyaline cartilage over the femoral head, making its way down to the lesser trochanter. So if we scan it's an odd joint in as much as that you don't scan very often or ever in the axial or sagittal plane. You scan the hip in the long and short axis of the femoral neck. And so this is the long axis view of the femoral neck. You can see that the iliofemoral ligament is displaced from the femoral neck here, and it has a convex nature to it. You can see fluid inside the joint space here. So this is a patient with a hip joint effusion. You can't tell on ultrasound why the patient's got a hip joint effusion. It may be that they've had trauma and they've got a hemarthrosis. It might be they have some synovitis. It might be that they have a septic joint and it's full of pus. You can't characterise the type of fluid as much as you would love to on ultrasound. If it looks a little bit cloudy, like it's got some echoes in it on ultrasound, when you aspirate it, it can often look completely, totally clear. And sometimes when it looks very clear on ultrasound, you aspirate it, it's frank pus. So you can't play the game of trying to pick whether or not this fluid is clear serous fluid or a septic joint. You have to tap the joint and aspirate if you have a hip joint effusion that you are wanting to get more information about. To do that, it's a simple matter of bringing the needle in. You can see me trying to find the good Dr. Gupta's needle here, and I found it now, and down it goes, and until we touch the neck of the femur, so we've gone through the iliofemoral ligament, touch the neck of the femur, you know that you're in the joint and you can aspirate or inject to your heart's content. So this is a patient with a nice small joint effusion, and there's the needle appearing, touching the femoral neck and being aspirated. So this is the simple anterior approach. There's a couple of other different described approaches, but this works very nicely. It's a very easy way to aspirate or inject project into a joint. It's very forgiving because you've got the whole width of the femoral neck to work on. The joint capsule, of course, is very broad, so it's not a needle procedure that you need to be exhaustingly accurate about. You can get the needle to the site quite easily. If you choose this location, of course, there's no hyaline cartilage to damage on the femoral head, and you're just going onto bare bone on the femoral neck. So this is a good, safe and easy technique. What's going on with this patient? So this is an example of one that's not so happy and healthy. So here we've got a concave femoral neck and we've got a convex iliofemoral ligament. And we can see underneath here there's a little bit of fluid. But what we're noticing mostly is how thick the iliofemoral ligament is up there. One thing I've fallen into a trap with this quite a few times is I scan it and I think it looks okay. I just think it's just a thick iliofemoral ligament. When you compare it to the other side, you remind yourself then what a normal iliofemoral ligament looks like. So always, if you're in any doubt that the iliofemoral ligament looks a bit thick, and scan the other side. This is how you make the diagnosis of a synovitis of the hip joint. And of course, synovitis of the hip joint is a reasonably common condition, so it's something you should be considering in your differential diagnosis for someone with hip pain, anterior hip pain, sort of groin pain type presentation. Now the labrum, we looked at the labrum. Here it is here. You can see it beautifully on a newborn baby, and here's the fibrocartilage limbus here on the labrum. So this is a dysplastic hip, of course, with an alpha angle of what would that be? Maybe 30 or 40 degrees. So well short of the required 60 degrees. A very rounded rim to the acetabulum here, and a subluxable femoral head that's coming really out and displacing this fibrocartilage limbus structure. So this is a dysplastic hip. Now, if you were born 10 years ago, no trouble. The paediatricians are all over this, and we have the graft technique, and we can diagnose all of these dysplastic hips. But if you're a bit older, like myself, then paediatrician, you probably didn't even see one. Probably just the local family GP had a bit of a look at you after you were born, and they weren't that flash. There was no ultrasound to have a look at hips. They used to use X-rays fairly sparingly. So many people of my generation have dysplastic hips that were poorly treated, and of course you run into sort of middle-aged anterior hip pain, and the reason you get that is often because of this undiagnosed dysplasia, that then means that the labrum has to work harder. In this area of the bony root isn't formed deeply enough, then the labrum has to work harder to hold the femoral head in position. You get labral degeneration, you get osteochondral defects of this hyaline cartilage at this component here of the acetabular roof, and early onset osteoarthritis, and you'd be at the tender young age of 50 or so having your first hip replacement, which is a bit of a shame. So this is quite a common thing. The other reason, which was only been described much more recently for people to get into trouble with early onset osteoarthritis in the hip, is because of the femoroacetabular impingement syndromes. And there's two different described types. This is a normal hip where you can see the femoral head sits beautifully into an acetabulum that looks well designed for it. And during complete hip flexion, the labrum never makes contact with the femoral neck. It's a good design. If you have a pincher abnormality, it's much the same as having the opposite to a dysplastic hip. So in other words, the femoral head sits inside a cup, inside an acetabulum that is not too shallow, but paradoxically too deep. So it sits too far inside it. And when you go into hip flexion, you notice that the neck of the femur hits into the anterior hip labrum, and will damage this and damage the chondral margin along here and cause early onset osteoarthritis. We can't see this with ultrasound, but if you see an anterior labrum that has a paralabral cyst and some degenerative change, you need to have a plain AP pelvis done to see if we have this in the background going on. The second type we can sometimes see with ultrasound, although the plain X-rays are still a much more potent tool to diagnose it, and that is the so-called CAM abnormality. Now, a CAM in your car run smoothly. If you have a round femoral head, that's quite normal. If you have this bit of extra bone here, the shaded area, this is the CAM abnormality. So once again, if you go into hip flexion, the CAM abnormality contacts the anterior labrum and will damage this chondral area here, and you'll have an early onset of degenerative process, and you will lead down the path of osteoarthritis at a young age. So the pincher and cam abnormalities are things to consider, and you should always have an AP pelvis. It's probably my second favourite X-ray after a PA chest X-ray. What's not to love about that? But an AP pelvis is a very, very powerful X-ray. It allows you to look at the sacroiliac joints, at the symphysis pubis, at the hip joints. It's a wonderful radiograph to have a look at, and you can certainly diagnose pinchers and cams quite easily with that in your back pocket. So what happens if you've got a cam or a pincher, or if you're just unlucky and you've got labral tear starting to happen? This is a person that is terribly old. This is in their mid-40s, and they have this large, complex-looking paralabral cyst. So if you look at where the labrum sits down in here, you can see indeed that there's a little bit of sclerosis of the bone here, so it doesn't look completely normal. But I would find it still difficult to really comment on the status of this labrum here. However, the paralabral cyst gives it away, just like the parameniscal cyst in the medial joint line of the knee, or the paralabral cyst in the suprascapular notch of the shoulder, or the spinoglenoid notch of the shoulder, give away the fact that there is an underlying labral tear. So you don't see the tear directly, you don't see the cleft in the labrum, you see the paralabral cyst. And of course the paralabral cyst forms because the joint has been opened by the tear, the synovial fluid tracks through the little crack in the labrum, gets to the outside weld outside the iliofemoral ligament, and then forms almost like a false aneurysm of synovial fluid, and then that dehydrates over time, forming the hard ganglion, and that's what we see sonographically. This is another example of an anterior labrum tear. You can see that the iliofemoral ligament is displaced anteriorly, and the labrum looks totally disorganised. So while there's not a large extruding paralabral cyst, there are indeed lots of myxoid degeneration and a complex ganglion sitting in the area of the labrum, and I wouldn't really have any hesitation to say in a case like this that you have some significant labral disease, and they'll go on and have the appropriate CT arthrogram or MR arthrogram to investigate the anterior labrum. So as so often ultrasound does, we end up being a triage agent where we can sometimes make the diagnosis, and that's very satisfying when we can do that. And then on other occasions, we simply triage the patient to the appropriate test. And as far as that being part of the role of ultrasound, I think that's entirely appropriate. The cam abnormality, remember this is where the femoral head has a bit of extra bump. So here's the acetabulum, here's the femoral head. Have a look at the shape of this one. You can see how it just sort of keeps going, and it doesn't really swan down into that sort of neck of femur until way too late. So there's a whole lot of extra bone here. If I run that clip again, you can just appreciate that again, that there's some extra bone that just lives in this area just here. As we sweep inferiorly, you'll see it. It just keeps on going. It's not a round femoral head. It's got an extra block of bone there. And this is a sonographic example of a CAM deformity. The plain X-ray will back you up, and sometimes the quite obvious ones on the plain X-ray are very difficult to see with ultrasound. So I would never advocate that ultrasound be the primary test for diagnosing a CAM deformity. But when you notice one with ultrasound, it's worth then just having another look at the plain X-ray of the pelvis to see if you can see it or not. Once you've had a look at the anterior hip joint capsule and had a look for an effusion, had to look at the labrum area, the next thing I always tend to go to next with a hip joint is the flexor apparatus. Now, the flexor apparatus is a little complicated, and there are many hip flexors. Some of them are strong and some of them are weak. The weak hip flexors I'm not really going to bother with too much. They would include pectineus, sartorius, and tensor fascia lata muscles. These are all capable of flexing the hip, but they're small players compared to the major drivers that are the iliopsoas apparatus and the rectus femoris. This is, I like this slide. It's quite pretty. I use this slide for teaching my athletic pubalgia type material, all of my inguinal canal, femoral hernia type things, and I also use it to demonstrate the hip flexor apparatus of the hip. So this is the iliopectineal eminence that comes off, of course, from the symphysis pubis. You can track it across, and this is just above the level of the hip joint. So it's if you imagine the little acetabular rim just above the hip joint in the long axis, if you go 90 degrees for that and push the probe up towards the patient's contralateral shoulder, so that you're in the short axis of the femoral neck, coming up onto the iliopectineal eminence, this is the anatomy that you'll see. And in this picture, you can see this is the psoas muscle belly here. These are the medial fibres of iliacus, and these are the lateral fibres of iliacus. The combination of psoas and these two bundles of iliacus make globally the iliopsoas apparatus, and they make the iliopsoas tendon, which sits here. Deep to that, between it and the iliopectineal eminence, is the iliopsoas bursa, and this is a very important structure. So on this image, we need to look at the medial fibers of iliacus and the iliopsoas bursa with most scrutiny, because the psoas muscle is a very strong, powerful muscle. It does not have much range of movement. It has a very short contractile distance, but it is very, very strong, so it rarely tears. It suffers other problems. It loves to get an abscess inside it, and it loves to get an uncontrolled bleed where you get a large hematoma inside it. But it does not really suffer from stress-induced tearing, as opposed to the medial fibers of iliacus, which loves to suffer from that. The lateral fibers has its own little tendon as well, which I haven't really got on this diagram, and that's a fairly benign area for tears as well. So that's that group you can look at globally. And then the second one is the rectus femoris, which attaches to the anterior inferior iliac spine. The rectus femoris is has an interesting origin, and I'll get to the detail of that fairly shortly. So we're going to look at these hip flexors, and then we're going to look at the rectus femoris as well. The iliopsoas tendon insertion is a nightmare, and it's very difficult to see. We have a technique where we can see the insertion of the iliopsoas tendon onto the lesser trochanter, and disappointingly, after all the effort went into sort of devising the technique, it has yielded us very small amounts of information. So it would appear to me that the actual insertion of the iliopsoas tendon, this is the combined tendon that's made from the medial fibers of iliacus and the psoas muscle, that combined tendon attaching onto the lesser trochanter of the hip joint is a fairly benign area. So there is a technique, and I'll show you how we do it, but it's not much of a problem. The musculo-tendinous junction is far more interesting, as is the iliopsoas bursa. So it's sort of like the perfect worst case scenario. You can see that this tendon comes down and attaches here onto the lesser trochanter. It's really deep. It's deep down inside, right underneath here. If we could peel the sartorius way, which is this muscle here, you get closer to seeing it in underneath there, and it wraps in right around the back of the lesser trochanter. So imagine what the thickness of tissue you're scanning through here is very difficult. And of course, you know that in this part of the anterior thigh, you also have the femoral neurovascular bundle. And you know that because it always sits immediately deep to sartorius. So if you can peel sartorius off, you'll see the femoral neurovascular bundle. And so a neurovascular bundle is a very poor acoustic window. It has many interfaces. It always contains fat that separates the structures. So this is a bad spot to be scanning through. So we need an alternative. The alternative is, and this is to get to this spot here, which is the iliopsoas tendon insertion, is to bring the probe right around into the midline. So it's a very intimate examination, and you shine the torch, if you like, through the pectineus muscle and the adductors to get to the iliopsoas attachment onto the lesser trochanter. It is an intimate examination. You should, if it's a male, you have the back of your hand pushing their scrotum out of the way so that you can achieve this view. But what it does is it avoids this neurovascular bundle here, and you can see that this is a nightmare of an acoustic window. This is a beautiful acoustic window. It's really very similar to using the pronator teres to have a look at the biceps brachii insertion onto the radial tuberosity. In fact, this idea came about after that technique was developed. So it's another way of seeing difficult insertion. Unfortunately, unlike the biceps work, this hasn't really yielded much pathology. So we get nice pictures, but we don't often get a diagnosis. This is what the image looks like. There's the lesser trochanter, and here's the beautiful iliopsoas tendon coming down and attaching. We do see the occasional enthesopathic disease process here, some occasional calcification inside the tendon here, but rarely is it torn, rarely is it tendinopathic. It seems that it's just such a big tendon that it doesn't have too many problems in that regard. So to get from the hip joint to the iliopsoas, we need to go from a long axis image here to a short axis image here. So if you watch this clip carefully, at the beginning, you'll see that I'm in the long axis of the hip. Here I am. Then I turn 90 degrees, and then I slide the probe up towards the patient's contralateral shoulder until I get to this piece of anatomy here. And this piece of anatomy, I'll go through with you so that you can understand it. So if you can still see the femoral head and the hyaline cartilage, you're too low. You need to slide your probe a little bit more towards that contralateral shoulder. This is the image you end up with. It's beautiful. And if we go through this bit at a time, that is the iliopsoas tendon there, this round ball of echogenic collagen. These are the medial fibers of iliacus, and they have this nice little crescent around the outside. So a beautiful little ring that demarcates the lateral fibers of iliacus from the medial fibers. These are the ones that get damaged with a rapid hip flexion injury, such as an athlete would have, kicking a football that's being smothered, or anything that involves hip flexion against resistance. The lateral fibers of iliacus is a much bigger muscle and sits out here, and is a fairly benign area for pathology. And this is the psoas muscle over here. And you can see it's almost triangular, little psoas muscle sitting here. If I could increase my field of view a little bit, what you'd see next over here would be the femoral artery and vein and femoral nerve complex sitting in this corner. Where I want your eyes to go, most importantly, is to here, which is the iliopsoas tendon. If I just take that way again, you can see that there's very little separation between the posterior fibres of the iliopsoas tendon and the iliopectineal eminence. Very small distance. They should almost be touching each other, kissing each other. The amount of separation here is enough for me if they have hip flexion pain, so if they get pain with hip flexion, that is putting on a trousers, getting in and out of a car, walking upstairs, then this will be injected with some corticosteroid to see if we can reduce the inflammation. So even a very subtle bit of bursal thickening is enough to act on. The second part I need your eyes to go to are the fibres of the medial fibres of iliacus, and that's this area here, because this is where you'll have the tears that occur. So make sure your eyes go here, and you won't go too wrong. This is a beautiful case of the medial fibres of iliacus with, if you like, a corky or a hematoma sitting within them. You can see here how the medial fibres grip onto the iliopsoas tendon, almost like a tug of war, and on the opposite side you can see they've been shredded away and you can see the large hematoma. This is a clip showing the same thing. So there's the tendon down here, and these are the medial fibres of iliacus, and you can see the large hematoma sitting inside it. So this is a hip flexion injury and very painful for the patient. So take your eyes for that spot. What about the bursa? Well, this is normal. You can see here we have kissing collagen, kissing the bone. Beautiful. And there's the medial fibres of iliacus, nicely demarcated. But if you contrast that to this one here, you can see there's a very large gap between the posterior fibres of the iliopsoas tendon and the iliopectineal eminence. This large gap with some fluid sitting in here is a very large and obvious iliopsoas bursitis. So it's a little bit like the shoulder in as much as, well, even a lot like the shoulder in as much as a bit of bursitis will cause just a small thickening here, but not fluid. If this, however, is communicating with the hip joint, which it does in a reasonable percentage of people, then fluid from the hip joint, if there is an effusion, will fill this iliopsoas bursa. So this very fluid-filled bursa is really not just bursitis, but a communicating iliopsoas bursa, which is being flooded with liquid from the hip joint. This is a more complex one here with a few septations through it, but same pathology. I've noticed in recent times, and I was a bit puzzled by this cute little appearance of almost like a baker's cyst that wraps around the edge of the iliopsoas tendon. Here it is here. You can see it like a little baker's cyst. If you put your finger in here in a cadaver, like those of you that went to the Anatomy Day recently had a chance to do, you see, stick your finger up in here and around the corner. There's actually a bare area on this side of the iliopsoas tendon. So as the iliopsoas bursa fills, it can wrap around the iliopsoas tendon and sort of separate it from the medial fibres of iliacus. And this little crescent-shaped fluid collection is an iliopsoas bursa full of fluid. And again, because it's got fluid in it, I would suggest that it's a communicating one and is a reflection of other hip joint pathology as well, not just a pure iliopsoas bursitis. Here's a bigger example of the same, and you can see that they often, this one's got some synovial proliferation. You can see it's quite thick-walled and gungy. So this is a synovial proliferative process. You see some vascularity in these on occasions, this synovium. So this is an iliopsoas bursitis with some frank fluid as well. They can get massive. Whenever you see a large fluid collection anterior to the hip, always think of a massive iliopsoas bursitis. They can get so large that they can extend halfway down the thigh, all the way up sort of and poke underneath the inguinal ligament. They can be very, very large indeed and quite confusing on ultrasound. You've got no hope with ultrasound, I don't think, of being able to really characterise it accurately, and that will be left to the larger, more panoramic cross-sectional modalities. But when you see the large collection sitting anterior to the hip joint, always think iliopsoas bursitis and put that on at the top of your differential list. It's going to be a common thing. Indeed. Now the other hip flexor, which is a bit interesting, is the rectus femoris. Now rectus femoris is a dual-headed tendon. There are many of them in the body, of course. Pronator teres, flexor carpi ulnaris, a couple that come to mind. And the rectus femoris has a straight head, which is here, and then a reflected head, which it's always difficult on these netta pictures to see exactly the line of this. It looks like it's parallel to the straight head, but this one's actually pointing far more posteriorly. So you've got to tip the top end of the transducer back a long way posteriorly, probably about 60 degrees, and it attaches just onto the lateral edge of the rim of the acetabulum. And this is the reflected head. So it's a beautiful redundancy, much like the vinculum system in the flexor digitorum profundus or the dual heads in those other muscles. You can rupture one head, the other one will hold it in place. It's a bit like, I suppose, the lacetus fibrosus or the biceps aponeurosis in the distal biceps apparatus as well. It's a bit of nice built-in redundancy, and I'll show you how it works. So if you could line up the anterior inferior iliac spine and then put the probe into a straight sagittal plane. Remember, now we're looking at not at a hip joint thing, but one of the flexors over the top. So this actually does run in a pretty straight sagittal plane. So your probe is now not parallel with the neck of the femur, but just parallel in the sagittal plane. You'll see beautiful collagen here, and then you'll have this diverging collagen heading more posteriorly here. This black area here is not pathological. This is normal. And this is the reflected head coming down. So there's a bit of a pitfall here where you can think that you've got some tendinopathic process at play here. In fact, you do not have that indeed. If you then tilt the probe, come a bit laterally and tilt the probe back posteriorly, you can see the reflected head, and it comes down through here and attaches onto the rim of the acetabulum on the lateral side. The muscle that sits immediately adjacent to it is the gluteus minimus muscle. So you can actually see this nicely when you do a lateral hip. If you come up in the short axis, you can line this back up and you can really appreciate the relationship between these bits of anatomy. And I'll show you a very long clip soon that demonstrates all of that so nicely. So here we have the AIIS in a short axis, and now we have its long axis. And here's this sort of artifact that you get, if you like. And when you come laterally and then posteriorly, you can line that up to produce this beautiful picture of the reflected head. So here's the straight head in long axis. Here's the reflected head. Take the probe laterally, tilt the superior end of the probe posteriorly about 60 degrees, and then follow this collagen down. What you will notice, though, with this bit of collagen here of the reflected head is that it's a little bit flaccid, so it's not pulled tight. And that's normal with a patient laying in a neutral position. You can see it's a little bit what I call crinkle cut, so you get the sort of areas of anisotropy and isotropy adjacent to each other. It's very easy to tighten this up, and you can see me doing it here. And all I'm asking them to do is I'm asking the patient just to lift their heel of the same leg, just slightly off the table, or take the weight of their leg into the air, and that will tighten the rectus femoris. If you just ask them to tighten their quads, it doesn't work so well. I'm not sure why, but it doesn't. So this is a good tightening maneuver, so you can straighten the collagen out and actually see that it is attached to the rectus femoris muscle belly, because of course when it's detached, this will not happen. It won't be able to pull on it, and we'll show you some examples. Here we have a 25-year-old footy player scanned not long ago, just a couple of months ago, and a rather tragic result here where he's got a very badly retracted rectus femoris. So you can imagine what his thigh looked like. The proximal thigh was scalloped out. The distal thigh had this, looked like he had his wallet underneath his jeans halfway down his thigh. So when you see this pattern, you know that both heads have to be disrupted, because if you have exploded your straight head off of the AIIS, the reflected head should still hold this muscle belly up. Just like when you see a long retraction proximally of the biceps brachii tendon when it's avulsed, you know that the lacetus fibrosus must be torn as well, because you've lost not only the main primary holder, but you've lost the redundant tendon as well that's supposed to protect it. So we knew what to see here. The next question when you see this is, has it all pulled off the bone? Has there been an avulsion fracture? Or have you got a mid-tendon rupture, or is it a musculo-tendinous rupture? Of course, the worst ones are the musculo-tendinous ones, because they're the hardest ones to fix, because you have nothing at this end to stitch into except a stake, essentially, and the sutures will pull out of that, and that makes it very hard to manage. So here we have the retracted end of the rectus femoris. Here we have the straight head of the rectus femoris tendon here, and we can see the reflected head coming down, and this is torn in this area here, so you can see it's a musculo-tendinous junction tear. When we ask him to tighten up his quads, you can see it's very bull-nosed here and a lot of hematoma. When we ask him to tighten up his quads, what we see is the muscle contracts rather, and it's not really pulling on anything above, so it's a complete tear. If you then have a look at the top, you can see that the reflected head on the good side, on the opposite side, looks beautiful, and the reflected head on the affected side is very black and looks detensioned. Here it is in real time, and you can see as I come across and then posteriorly to show that reflected head, you can see there's the straight head there that's retracted, and here's the reflected head that looks swollen and black, and it's torn down here at the musculo-tendinous junction. So this is a dual head musculo-tendinous junction injury, which in terms of management is about as bad as you can get, unfortunately. It's really easy to stitch collagen to collagen. It's really easy in relative terms, I suppose, to put a bone anchor so that you can attach it back onto the, put an artificial enthesis back onto the AIIS, but musculo-tendinous ones are very difficult. This one's a bit different. You can see here and here the avulsion fractures. So this is the anterior inferior iliac spine that's been avulsed from the bony skeleton of the pelvis. So we know that we're going to have a problem here with rectus femoris. We know that it's come away. The question is the reflected head still attached, and what else is going on? Those of you with eagle eyes will notice this patient also has a large cam deformity of their hip joint, and I actually have only just noticed that myself staring at these images tonight. But there we have a cam deformity as well, and you can see a bit of early onset OA change as well. So, so this person is not going too well with their hip. And this is the same patient, and they are 39, so quite young. Here's the AIIS, and we can see there's the bony fragment that we could see on the plain x-ray just there. So it's only retracted maybe what, that's about 1 centimetre. So this tells me that it's an avulsion fracture. So we have all the collagen still attached to this bit of bone here. So we can bring this up and we can bone anchor it back here. That's good for management. The minimal amount of retraction tells me that the reflected head, I would suspect, is still intact. The other thing that I notice is this bit of fluid coming up through here. So what's this bit of fluid here? Let's have a bit more of a look at that. This is a good clue to these cases because they bleed heavily. If you go into the short axis, you can see here's this sliver of fluid here. And what it is, it's some fluid tracking up between sartorius and the lateral fibres of iliacus. Now, that track of fluid there, when I started scanning this patient, was the first thing that caught my eye. And I remember because it was only a couple of weeks ago. These are very common, these injuries. So fluid here equals an injury in underneath it. And you can see, if you look at the AIIS in the short axis like I am now, look at the top, it's very ragged. And that's because the avulsion fracture has broken that apart. And as we go distally, you can see the avulsed fragment. And there it is just there, beautifully. And you can see it on the plane rays. In the long axis, we go down and have a look at the reflected head. And it looks pretty good. So the reflected head's nice and tight. The straight head is avulsed, but the reflected head is good. So this, in terms of management, is much better than the last case I showed you. A bone anchor of the straight head back onto the AIIS, and it should be very strong and able to enjoy a lifetime of athletic pursuits. This is a beautiful case. These pictures, how nice are these? These are good pictures and compliments of Qantas Serlin from Melbourne. Awesome guy, great sonographer, and the prettiest picture maker I know. And this is quite a recent case where you can see the musculo-tendinous junction of the straight head has retracted back to here, and the reflected head has recoiled almost like a rubber band, and you can see the crinkle cut change in the muscle. So this is a dual head avulsion off of the bone. It hasn't taken much periosteum with it. There's no avulsion of anything bony, but there's a lot of collagen here, and that can be bone anchored back on, and both heads have to be reattached in this case. A very nice example. The last pathology in the rectus femoris is the calcific tendinosis, and these patients will be so painful. You know what they're like in the supraspinatus tendon when they have this milky calcification, and when you see this in the rectus femoris, it'll be the same. You aspirate these with a large gauge needle and you get these plugs of Colgate toothpaste out of them, and they'll feel much better. So a patient with hip pain and guarding and stopping you from really scanning them, always think anyone that's got that guarding, crying type pattern going, that calcific tendinosis is often the answer to it. Now, around the side of the hip is the Abductor Apparatus. So these are the hip abductors that move them away from your body. So it's the way you swing your leg outwards. There's two muscles, the minimus and the medius, that we consider here. They have very different tendons. The minimus has a very long, slender tendon, and the medius has a very broad and much more muscular-influenced tendon. So they're quite different. This one, I think sonographically looks more like a supraspinatus, and this one looks more like a long head of biceps. That's how I equate them to the shoulder. If you take your probe, patient decubitus, and you point it out, if you make 12 o'clock straight up there towards the axilla, point the probe out to about 1:30, you'll be in the correct line for minimus. If you then take the probe and you put it round to about 12:30, you're in the right plane for medius. Medius has two heads, one here on the lateral facet and another one that comes round onto the supero-posterior facet of the greater trochanter. If you then take your probe round a bit further, more posteriorly, you get that second head, and you can see that there. If you keep coming around the back, you get into the posterior hip facet, so the posterior facet of the greater trochanter. And if you've got your probe lined up between the posterior facet and the tradesman's crack, so the natal cleft of the patient's buttock, then you'll be in the line of piriformis. And then if you come around into an axial plane, you'll be in the line of obturator internus. So we'll walk around these five tendons. This was came out not that long ago. It's a beautiful schematic, essentially doing the same job as that one I just showed you. So at 1 o'clock here, 1 to 2 o'clock, you've got Minimus. Straight up, you've got Medius. Come around a bit further, you get Piriformis, and come around a bit further around to 9 o'clock, and you've got what they call conjoint tendon. The conjoint tendon is formed by the superior gemellus, the obturator internus, and the inferior gemellus that genuinely do form one tendon that attaches onto the posterior facet here. The piriformis also communicates a bit with this conjoint tendon. There's some sharing of fibres, but you can see it as a separate structure on ultrasound if you get a nice bum to scan. It's no good looking for this on Nana or that, or overweight people, but if you've got a nice bum to scan, you can really pick this anatomy quite well apart. This is my schematic of what a lateral hip looks like. If you put the probe in this position here, so you're in a straight axial position, you can see the gluteus minimus sitting on top of the anterior facet of the greater trochanter and the medius sitting on top of the lateral facet. Minimus is very round, like the biceps, and medius is quite broad. Beneath them are two bursae, the subminimus and submenius bursa, respectively. And on top of them is the iliotibial band, which is a thick fibrous structure. I always feel it's nonsensical to say in a report or on a worksheet the iliotibial band appeared thickened, because it's always thick. It's like the CA ligament. It's not the thickness of it that matters. It's what it does to the structures underneath it. So thickening of this means nothing to me. I think it's thick in everybody. The Gmax integrates into the posterior part of the iliotibial band, and it's tensioned anteriorly by the tensor fascia lata muscle belly. So these are the tensioners of the ITB. When we move our hip around, the lateral and anterior facets move, and minimus and medius are attached to them. So this block of tissue here all moves together. The ITB stays stationary. Now that gives us a friction plane through here, and this is where the bursa, that some people call the trochanteric bursa and some people call the submaximus bursa, resides. This is the very large bursa. This, of course, is fatty arse-osis, which is variable and is the enemy of good ultrasound. So the more of this they have, the lower frequency you use, and you may end up using that beautiful convex 10 transducer on the TOSH, which does a beautiful job for the lateral hip in the bigger patients, and scan through the layer of fat, and beneath that, magically, you find the same anatomy. It's just the resolution will suffer a little bit. If you move the probe a little bit cephalad, so towards the patient's head, you will notice a change, and the change is in the gluteus medius, and that is it's come off the bone now and it flourishes into a very big muscle belly very quickly. So the muscle in front of minimus is medius. So you've got the minimus tendon with medius sitting in front of it. The muscle in front of the gluteus medius is the gluteus maximus, and those rules are never broken. These are what I call navigation rules. The iliotibial band and the submaximus or trochanteric bursa always lies on the surface of gluteus medius. So it sits on the surface of medius. So this is how I scan them. I find what I call the pyramid. So I put the probe on the lateral hip and I can see the anterior facet and the lateral facet, and that looks at you like a pyramid on the screen of bone. Then I slide the probe posteriorly, and as I'm sliding it posteriorly, you can see it slides back to that supra-posterior facet. You'll see another kink up here where the other head of medius attaches on. This is the minimus footprint on the anterior facet. This is the medius footprint on the lateral facet. On the supra-posterior facet, you can see that medius also inserts there with the second head. And this posterior facet, at the top part of it has piriformis, and then the lower part of it has the conjoint tendon, which is the superior gemellus, obturator internus, and inferior gemellus conjoining to make one collagen band to go onto the posterior facet. This is my pyramid right here. This is the top of the pyramid. The anterior facet here has minimus, and you can see it there. The lateral facet here has medius, and you can see the difference. This muscle that's flaring out in front of the minimus tendon is, of course, gluteus medius. And sitting in front of that, this is the iliotibial band, this broad structure here. This is a fairly fit 54-year-old female. That's a nice bum to scan, and she has a good gluteus maximus that extends a long way around. When you maintain fitness, your gluteus maximus comes further around. If this is an older person or someone not exercising, the iliotibial band will extend back here, and the gluteus maximus will be more posterior. This is a fit 54-year-old female. So let's have a look at a bit more anatomy here. Here's the anterior facet, lateral facet. So now we can see the medius tendon, fairly flat, sort of broad tendon. And then I've come a bit further around to this extra facet. This is the supra-posterior facet, where the other head of medius attaches. Now with medius, the front part is most vulnerable, the most anterior part close to the pyramid. And this posterior part, this supra-posterior head, is very tough. It's very similar to the tearing pattern of supraspinatus. If you start from the biceps, if you call that the apex of the pyramid, the supraspinatus peels from front to back. So it peels off anteriorly, and then when you get, the more posterior you go, the more it's reinforced by infraspinatus, and so the tear generally is halted at that area. The tears of gluteus medius start anteriorly, and as you head posteriorly, the influence of the other head of medius on that supraposterior facet toughen it up and prevent the tearing from extending any further. And that's what stops the medius coming away from the bone entirely. This is the minimus now in its long axis, and I might just stop that video, not a bit slow, we'll let it go. This is the minimus in its long axis. I'll wait for the video to get back to the start again. And you can see how it very much is like a biceps tendon. Here it is here. Here's its attachment, the end thesis here. If we then slide the probe proximally, like I'm doing there, you can see this is the medius muscle belly, and this is the minimus muscle belly, and this is the joint capsule. So the lateral hip labrum sits just in here, just there. This is all joint capsule here. So the value of this image is to look at the health of the muscle bellies. This is the medius muscle belly and underneath the minimus muscle belly. And what I'm looking for is to see they're both black and beautiful. If you get fatty atrophy change of either of those, that will tell you that the patient either has a poor recruitment pattern of that muscle, or in fact the tendon is damaged or torn. And the rehabilitation is dependent on the health of that muscle belly. So it's very important information. You can do the same in short axis. Here's minimus and medius. And as I come up in short axis, these labels will make sense. So there's the medius muscle sitting on top of the minimus muscle. What's this thing here? That thing there is the reflected head of Rectus femoris. So when you go home and do this tomorrow, to work tomorrow, you'll be able to see what I mean when you do this. Medius here, minimus here, there's the reflected head, another way of seeing it coming in from the side there. So this is a short axis assessment of the muscle bellies. So whenever you have abductor pathology, have a good look at the muscle bellies and comment on your worksheet about the relative atrophy change or otherwise of these two muscle bellies. That's what I'm doing with the probe. I'm sliding it up this way into the muscle bellies. It's very easy to do just from the pyramid. When we inject the lateral hip, you've got three bursae to consider. This is the trochanteric bursa, submaximus bursa. It's much, much larger than drawn here on this schematic. There's two others, one that sits underneath minimus and one that sits underneath medius. So here's the medius one, here's the minimus one. They have a very short enthesis. There's the enthesis, and then a large bare area where you have collagen sitting on bone. Whenever you have collagen on bone, like the iliopsoas tendon, you will always have a bursa. And so these bursae are easy to inject with ultrasound, and we would generally try and inject the trochanteric bursa always, plus one or the other of these, depending on whether we think it's minimus-based pathology or medius-based pathology. If they all look okay on ultrasound, if they're more tender over their anterior facet, we'll do the minimus one, as well as the trochanteric bursa, and if they're more tender over their lateral facet with sonopalpation, we will do the submedius bursa as well as the trochanteric bursa. So they get two for the price of one if they come and see us, which is quite nice. So for needlework, you have to go straight through the fatty arthrosis like a harpoon. Here it comes, and this patient must have had lateral facet pain or gluteus medius tendinopathy, because we've gone straight through the medius into the submedius bursa here. We inject about maybe a third of the aliquot into this, and then we extract the needle back out into the trochanteric bursa, and we inject the rest of the aliquot into the trochanteric bursa. This is a patient with minimus-based disease or anterior facet pain predominantly. It comes through into the subminimus bursa and then gets withdrawn into the trochanteric bursa. So the same process. So it's very easy to do, two for the one. I needle these with my radiologist, hold the probe in the short axis because I can see all of this global anatomy. It's the way that I find it most easy to navigate. There is, of course, this friction plane between, I'll just go back a slide just to highlight this. This is the friction plane here between the iliotibial band and your minimus and medius. I'm going to show you a way of moving these structures while keeping this stationary. And what you need to do is you need to ask the patient to lay into cubitus, keep their knees together, and then to separate their ankles. So, of course, the ankle closest to the table can't be moved. The other ankle has to be lifted towards the roof. So separating of the ankles, keeping the knees together. So not like a clam maneuver where you separate your knees, keep your knees together, separate your ankles. And what you see is the iliotibial band stays stationary and the abductors move underneath. And that shows you, even if it's difficult in the large patient, where the trochanteric bursa is and where the friction plane is. You can also help to use this if you think that the gluteus medius is absent entirely, so it's gone. You have what I call a bald facet. So what that means is that when you move this, the bone will move and it will articulate directly on the undersurface of the iliotibial band. So you've lost one of the spaces here. One of the layers is missing. So it's very handy to prove that in fact there is no minimus or no medius respectively, because it is articulating the ITB directly upon one of the facets of the hip joint. This is a nice case of some tendinopathy of minimus and medius. So there's minimus in the long axis. Now we're coming around to the medius. This is the left hip, so it looks backwards to you now. Look how black and ugly this medius is, and you can see minimus is no better. So this is classic tendonosis. There's a big, fat, swollen black minimus, and then you come around onto the lateral facet, and medius looks exactly the same. And there's the iliotibial band sitting over the top. There's not really any hint here of any bursal pathology, just tendinopathy. And we use platelet-rich plasma with these patients to some good effect now. We've been doing them for quite a while, and it seems to be a reasonable way of addressing this tendinopathy process as we would in a patella or Achilles tendon as well. Is the anterior facet here. This is our minimus. It's a bit swollen, but when we come around to medius, there's this large defect here where there is no medius, and then what's left of it, the posterior part, is very thick and black. So there's minimus looking swollen and tendinopathic. Is the anterior tear in medius, and there's the tendinopathy of the remaining posterior part of gluteus medius. So if you think of this as the biceps tendon, the anterior supraspinatus would be torn, and then as it starts to interdigitate more posteriorly infraspinatus, that posterior part is remaining intact. So it's a very similar pattern of tearing and pathology to what we see in the shoulder, in the hip. Think of it the same. It's like peeling, like opening one of those cans of sardines that peel from one corner back to the other corner. Fluid's a bit tricky, right? When you see fluid in the lateral hip bursa, in the trochanteric bursa, always think about a tear. When you see fluid in the subacromial subdeltoid bursa, you don't think about bursitis, you think about a tear. So when you see frank fluid like this here, and we wait for the beginning of the clip, if it runs again, here we go. Down here, this is posteriorly here, of course. This is in the trochanteric bursa, around the posterior facet, and this is medius, and then this is minimus, and this is the muscle belly of medius here. Superficial to that, of course, sits the trochanteric bursa. Remember that the trochanteric bursa always sits in front of the gluteus medius muscle belly. So this is fluid, frank fluid. When I see this, I think tear and fluid down here. I call this the saddlebags because you don't really see the fluid over the apex of the pyramid because that's a high pressure zone. The fluid gets displaced out more anteriorly and more posteriorly, so you need to go hunting for it. And if you just walk your way through the surface of gluteus medius, you'll stumble upon the fluid. Another nice pattern of pathology is the post-operative hip. So in the post-operative hip, to put a hip replacement in from the lateral side, which most have been done for a long time this way, they're now developing more and more, they're putting them in from the posterior aspect, which I think is going to lead to deep lateral rotator pathology, but here we have it coming in from the lateral side, and what we see here is that the minimus and medius can be cut away to put the hip in. Now, once that's been cut away, then you need to put it back together. So with minimus, it's pretty straightforward. The minimus tendon can be stitched because it's nice and long. There's lots of collagen. Medius, though, is very short and very sort of meaty type tendon, and very often tendinopathic anteriorly. So when you stitch this back together, it's rather weak. So post-operatively, you will see a patient that's had an acute onset of pain when they're becoming ambulant with the help of their physiotherapist, or when they've just returned to home. And you can see this retraction here of the gluteus minimus muscle belly and a large lot of fluid and a bit of retained stump of the tendon here. So it's just come apart at the stitch line. You can see this now I've sort of drawn it out for you. You can see what I mean. It's fallen apart where it was stitched back together, and this is unfortunate. It's a good example of why you get this pain. Now, the worst part of the hip, right, the posterior bit, this is where it gets really tricky. You cruise around the posterior part of the hip, and we have a look at the GOC and the piriformis. So you need to have a look at the superior-posterior facet, where gluteus medius attaches on here, and then we need to look at the posterior facet here, where piriformis, superior gemellus, obturator internus, and inferior gemellus attach on. This muscle here, of course, is quadratus femoris, and this is the sciatic nerve coming through here. That's our ischial tuberosity. So this is a nice example here where piriformis comes on here, and you can see the way the two gemelli and the obturator internus make one tendon and go on here. So this is a sort of a blown up, this is an example of this area sitting in here, and it's what we see sonographically. Angle the probe towards the natal cleft, and you'll see piriformis. Axial, you'll see obturator internus. Netta doesn't really draw obturator internus very well. It's very muscular. It's not at all. It's all collagen here. It's got the muscles all inside the pelvis. This is muscular, the two gemelli. This is very tendinous, so it's not really quite like it's drawn, and it'll look different on your ultrasound. So this is our superior posterior facet here. Then what I'm going to do is I'm going to slide the probe around here until I get to lining the natal cleft. And you see this big bow tie of collagen coming in underneath, the piriformis coming in here. So there's the supra-posterior head of medius, and then as I swing the probe around, there's the piriformis. Do I see much pathology here? No, I don't really. But what I'm interested in is, are they tender in there? That's the main thing. If I then extend my search a bit further, so I start here, I swing it around to piriformis, that's where I am now, and then I take the probe and I descend a bit further distally. You can see this tough band of collagen here, and that's obturator internus. So this is medius, swing around to the natal cleft, that was piriformis, and now come down a bit lower, and this is obturator internus. So obturator internus and piriformis look very similar, and they all attach onto that posterior facet in this area here. So if they've got pain in there on sonopalpation, it's not unreasonable to inject that area as well. It's less common, but maybe 1 in 20 or so will give some medicine in that area as well. That's very nice. The other pyramid that's important is up here. So patients sometimes say, look, it's nice that you're doing my scan and you seem like a nice chap, but you haven't really scanned where I'm sore, and they're pointing much higher. And of course, they've been referred for query-troponteric bursitis, and the clinical history is nothing like that. So we need to look at the sartorius and the tensor fasciae lata origin, and then this direct attachment of the iliotibial band onto the iliac crest. So this is the tensor fasciae lata origin here. Sartorius is just in front, and a bit more posteriorly, this is the direct origin of the iliotibial band. And you get tendinopathy here and here that looks very similar sonographically to plantar fasciitis and can be very symptomatic. The way to find this is if you palpate the ASIS and then move the transducer in the short axis distally, this beautiful butterfly appears. And how nice is this? So this one in the front here is sartorius, and the one more posteriorly is tensor fasciae lata. So it's very easy to get this picture. This is a nice butterfly of musculature here. If you then come down and concentrate on the more posterior one, which is the tensor fasciae lata, and swing into its long axis, see its tendon attaching here. And it's a nice collagen tendon, no evidence of any tendinopathy whatsoever. If then it is tendinopathic, it'll look like a plantar fasciitis like this. This is the normal one. This is the abnormal one. You can see here how it looks much like a plantar fascia. It's hypoechoic swollen. You've got some irregularity of the bony enthesis, and this will be point tender for the patient, and they'll respond well to corticosteroid injection in this area. Some more nice examples is nice tendinopathy. So remember, if it's very close to the ASIS, just posterior to that, it is the tensor fasciae lata. If you come back maybe another 2 centimetres, it's not really the tensor fasciae lata, it's so much as the direct origin of the iliotibial band. It's probably semantics, but we can get it right, so we should. Beautiful. This is starting at my butterfly here, the ASIS. So this is the sartorius here. So it's the tensor fasciae lata and sartorius. If you then come around more anteriorly, you see your iliopsoas tendon, medial fibers iliacus, lateral fibers iliacus, and then come more posteriorly. This is minimus here with medius sitting over the top. And if I then come down a bit inferiorly, you can see the reflected head here of rectus femoris coming across. So this is like a beautiful little anatomical journey that I want you to all go on. Start at the ASIS, come down, identify a butterfly, move anteriorly, look at the Iliopsoas apparatus, and then start moving posteriorly, identify the gluteus, minimus and medius posteriorly, and then as you move distally, you'll see the reflected head of rectus femoris, and then you can follow the minimus tendon all the way to the anterior facet. So this is the iliopsoas, medial fibers, lateral fibers. This is minimus here, medius here. I then increase the depth a bit, move the probe distally, identify the reflected head of rectus femoris, then refocus on the minimus muscle belly up here, follow the collagen down, watch it sort of aggregate together, sitting on the anterior facet with the very thick iliotibial band sitting on top of it. It's very nice. The last thing I'll touch on is the snapping hip. There's 3 types. The external snapping hip, which is a pretty clinical diagnosis, like where the iliotibial band get caught on the pyramid, if you like, of the greater trochanter. Personally, I think this happens when you see tendinopathy of minimus, so they have a large minimus. Sometimes the minimus can be dominant, and the muscle belly of minimus can be a bit larger than some people, and in that case you'll have a big tendon, and it's that catches on the iliotibial band. The internal snapping hip is where the iliopsoas gets into trouble, and that's the one I'm going to talk to you about tonight. And the intra-articular ones are from a loose body or some other process like synovial osteochondromatosis that's led to loose bodies, osteoarthritis. And we're not going to be able to help with those, with perhaps the exception of being able to see a joint effusion, but we're very unlikely to see the loose bodies, much like in the knee, I suppose. So the external type happens here on the lateral hip. And what you see when you ask the patient to do whatever it is that gives them the trouble is you'll see this structure here, which is, of course, the iliotibial band, getting caught on a very large gluteus minimus tendon. So you can see the way that it's snapping and popping. If you look carefully, you can see the way the iliotibial band is made of two fascial layers. So the bottom layer gets caught, and then the top layer keeps moving, and then the bottom layer has to catch up, and that causes the click for the patient. This is the type that I like, the internal type. It's where the iliopsoas tendon has to move around the medial fibers of iliacus. So they have this interplay where they roll on top of each other. To test it, you put the patient into hip flexion and abduction, and then you put them into extension and adduction, and that's going to cause the snapping hip. The way you scan it is exactly the same as I showed you to do this beautiful picture of the iliopsoas apparatus. You can do this when you're moving the hip around because you're above the hip joint. So all the movement is distal, and you can hold the transducer in this position to get these beautiful pictures. So here we go into hip flexion and abduction, and see the way the iliopsoas tendon climbs top of the medial fibers of iliacus, goes up in the air a bit and then comes down. You can see just at the end, it clicks down onto the bone. It clicks down because a little bit of the medial fibers of iliacus get caught in underneath it, and as they're expelled, the iliopsoas tendon clicks onto the iliopexual eminence with that audible click. Now this is okay unless you do this all day. What's it clicking onto? Of course, it's clicking onto the iliopsoas bursa. So eventually it's going to irritate that and cause problems. Let's have a look at the next one. So here we go into hip flexion and abduction. Anytime you're ready, there it goes. It's up in there and then it's coming down. And so this one clicks down quite firmly as well. So a very, very similar process. And this is what causes the click. Here's another one. Up it comes. Hip flexion and abduction, and you can see the medial fibers of iliacus firing there, and look at this one, it ends up right up on top of it, and then it really snaps off and falls down quite hard. So this is an internal snapping hip. Yeah, you can make the diagnosis, and the important thing, I suppose, sonographically, is then you can say, look, it's not an intra-articular snapping hip, it's an internal snapping hip, and the management will be quite different. The intra-articular ones will go and have an arthroscope to clean out the loose bodies in the joint. These ones, there's not much you can do about them. The physiotherapies will do, in inverted commas, iliopsoas lengthening exercises, and we may inject the iliopsoas bursa to reduce the inflammation there and at least reduce their symptoms. But I've seen a number of ballerinas in particular that with the amazing contortions they put their bodies through suffer from this problem. And this, I think, was one of those girls. She's a 25-year-old female, so I think this was one of the girls at the sort of elite sort of ballet dancers, and this is very problematic for her in her career. Sometimes it's a bit different, and you get the iliopsoas tendon getting caught on a little thickening in the perimysium of the muscle. So as we go into this is the same patient, you can see the iliopsoas tendon here will come up on top of this thickening, this fibrous band, if you like. There it goes, click, and then as you bring the leg down, again, it'll click off the other way. There it goes, and you can see this is very uncomfortable. So there's a few different variations you can see, but the theme is always the same, is that the iliopsoas tendon is getting caught on something, and as it's trying to disengage from it, it's clicking down onto that iliopexual eminence, and it's irritating the iliopsoas bursa if you do it regularly enough, and therefore the patient is presenting the symptoms of anterior hip pain and an audible click when they go through their exercise.
I hope you enjoyed this archive edition of my hip ultrasound lecture. If you like this material, please visit birdultrasound.com.au to view a wide selection of freshly recorded ultrasound education material on a wide variety of topics. Happy scanning. Bye for now.